Good evening. Very warm welcome from the Spine Society Delhi chapter. This is a newer initiative to bring education down to your houses, and that also in the evening. And our executive committee from the Spine Society Delhi chapter has been very kind, and especially with the help from our secretary and our education chair, Dr. Guru, we have structured this program. This is a very, very targeted learning program. So if you have like today's lumbar nerve root injections, if you really know and want to learn injections, I think we can have a whole day conference just on the injections. There's so many of them. So, but we will start with the basic one, that's the lumbar root. As it is said, any surgery when you start, always start from the lumbar, then go to thoracic and cervical. Same is the true with this nerve root injections. Always master the technique in the lumbar spine, then you can progress to thoracic or cervical spine. In the lumbar, the two major blocks which help us deciding a surgery and treating most of our patients are the lumbar nerve root blocks. So we'll not be doing about radiofrequency ablation, facet blocks, epidural or caudal, which are nearly in history now. We will just be talking about lumbar nerve root injection. So I welcome you all, and this will be a monthly venture every Wednesday, 8 to 9:30. So I now hand over to our education chair, Dr. Guru, to introduce the faculty and speak more about the program. Thank you.
Good evening all, and once again I thank you all for joining, and we already have nearly 400 people logged in, and this is a initiative from Delhi Spine Society, and we are going to have a very focused learning sessions every month, 8 p.m. onwards, second Wednesday of the month, and you will keep getting updates regarding this in future also. And today we are going to have mainly focused learning on lumbar nerve root block, which is the basic thing which you can do in your OPDs and as a daycare procedure. And we are going to have 6 talks today with the literature review on the lumbar nerve root block. And we'll have a discussion in the end. You can all type your questions in the question box. So we'll take them up one by one. And we have 10 minutes, 6 talks covering everything from anatomy to pathophysiology to different types of nerve root block to technique to a video and lastly complications of lumbar nerve root block. Because it looks very simple, complications are rare, but whenever it happens, it's not very pardoning. So again, I encourage all of you to spread word and encourage your colleagues to join in. And we will also learn together with you all in coming future courses like we have on lumbar canal stenosis, we will have on spondylolisthesis, we will all have on TLIF only, MIS, TLIF separately. So we are going to have different sessions in coming future. And without wasting much time, I invite the first speaker, Dr. Sachin Sharma. He is the consultant spine surgeon at Sri Action Balaji Hospital in Delhi. And I invite Dr. Sachin to go over with his talk. Thank you.
Yeah. Thank you, sir, for your kind introduction. Let me share my screen first. And thank you, Delhi Spine Society, for giving me this opportunity to express my views on this.
Yeah, Sachin, we can see your screen. Sachin, you are muted. Sachin, you are muted.
Yes, Sachin, we can
Am
hear
I audible
you.
now?
Yes,
Yeah,
you're audible.
Yeah,
you can hear your screen now.
Yes, sir. Is it fine now?
Yeah, all good.
Okay. So why KYC is important? So in today's world, as we know that you cannot even do a single transaction from your bank account if you are not have if you haven't updated KYC. So same applies to the lumbar spine also. So what is this KYC in lumbar spine? So the customer here is the lumbar nerve root, and the Aadhaar card to this lumbar nerve root is basically the surgical anatomy. So that is why knowing surgical anatomy is equivalent to exploring the Aadhaar card before initiating any kind of lumbar procedure in lumbar spine, be it a block, be it a surgery, or even reading an MRI. So why is KYC important in lumbar nerve root blocks? So that is first of all to identify the culprit level, for a targeted drug delivery, for accurate trajectory, having a good post-procedural pain relief, and avoiding complications. So these are some of the important things that lumbar nerve root can be used. Now, the lumbar nerve root blocks is not a new thing. It has been since their 1950s, and this is a cornerstone of conservative treatment of radiculopathy. Each and every spine surgeon as well as the pain physicians are very, very well aware of this, and it has been quite there since 1950s. Now, I will restrict myself to the osseous anatomy as well as the anatomy of the nerve root so that the various things will be covered in the subsequent lectures. So coming on to the osseous anatomy of the lumbar neural foramen, as you all are aware, it is an opening on either side of the spinal column at each intervertebral level through which the spinal nerve root traverses. And it is not only the spinal nerve, it is again the arteries, the veins, as well as epidural fat, which is again present in the neural foramen. And as we all know, it is formed under the lateral aspects of the vertebral canal. These are some of the things that form the boundary of this neural foramen. So the anterior border of neural foramen is the intervertebral disc. The posterior border, it is formed by the superior and the inferior articular processes as well as the facet joints. And the roof and the floor, they are formed by the respective pedicles. Now moving on to the anatomy of the nerve root. So each of the nerve, it is formed by the dorsal and ventral root with the nerve root located in the intradural compartment. And a dorsal ganglion is located just proximal to the junction of dorsal and ventral root, containing cell bodies of sensory neural fibers in the dorsal root. Now again, the nerve root join to form a spinal nerve distal and lateral to dorsal root ganglion, which is then covered by a perineurium. And each of the spinal nerve divides into a large ventral rami and a smaller dorsal rami just outside the neural foramen. So this is a very basic diagram from the textbooks of anatomy from the initial part of our MBBS. So if we consider L4, L5 disc, so the L4 pedicle, the exiting nerve root at the L4, L5 disc is the L4 nerve root which passes below the L4 pedicle, and the traversing will be the L5 here. So keep in mind when you read an MRI and when you apply these blocks in your OTs. So yeah, this is very, very important. So we all are familiar with this exiting and traversing nerve root, but yes, let me show you how these nerve roots are arranged in the lower as well as upper lumbar nerve root. So if you see this diagram, so this L5 nerve root is just kissing the lower border of the pedicle. But if you see this L2 and L3, they are somewhat lower as compared to the L4 and the L5 nerve root. So they are just at the level of the disc level. So this is the main thing that we should keep in mind whenever we are employing these root blocks in the lower lumbar and the upper lumbar levels. So why knowing this dural anatomy is important? Because inadvertent injection, if we go into the medial part of the foramen, then this can lead to the inadvertent dural puncture, which is to be avoided whenever you are trying to give a nerve root block. So moving on to the arterial supply, we are done with the nerve root now. Going into the arterial supply, as you all are aware, the anterior axis is composed of anterior spinal artery, which supplies almost anterior 2/3, and the paired posterolateral axis, they provide arterial supply to the posterior third of the cord. So why is it important actually? I'm coming to that point also. So the blood supply of each of the nerve root, it is by a segmental manner, by a radicular artery, which is accompanying each of the nerve root. If you see this diagram, so the arteries, they are arising from the aorta. This is the left lumbar artery. This is the right lumbar artery. This is the anterior spinal artery, which we are going. And these are the radicular arteries, which are supplying the nerve root that is exiting out of the foramen. So if we go by in the thoracic spine, so these radicular arteries are derived from the branches of the aorta, that is intercostal artery. And in the lumbar spine, they are called as lumbar arteries. So a radicular artery typically divides into anterior and posterior radicular artery, but this division and the location is very, very, it varies in each and every case. And a recent retrospective review has found more than twice the incidence of radicular arteries in superior portion of foramen as compared to the inferior portion. And the caliber of these radicular arteries is around 0.2 to 2 millimeters. And whereas the needle, that spinal needle that we use for a nerve root block is 22 gauge, has a diameter of 0.72 millimeters. So there is always an inadvertent chance of puncturing or injecting into these arteries whenever we are applying the nerve root block. So this has to be kept in mind. Of note, an end artery that supplies the neural elements within the neural foramen is called as a radicular artery. Most of the time these are end arteries, but some of them, they may continue to supply the spinal cord, and they are then termed as radiculomedullary arteries. So that is why inadvertent injection of your dye or even your drug into these radicular arteries may sometimes lead to catastrophic incidents. Although radicular arteries at every spinal level supply the foraminal structures including nerve, dura, and vertebral bodies, most of them end arteries do not contribute to the arterial supply of the spinal cord. So this is a very fancy word that we are very familiar from the initial part of our MBBS, actually, the artery of Adamkiewicz. So first of all, it is present on the left side, and it is most commonly arises from T9 to L2. Again, the diameter is 0.6 to 1.22 millimeters. And similar to the radicular artery, the artery of Adamkiewicz is most commonly located in the ventro-superior or mid portion of the neural foramen. So if this is the neural foramen, if you can see in the diagram actually, so the neural foramen has got posterior radicular artery, the radiculomedullary artery, and on the left side there is artery of Adamkiewicz. So whenever you are applying any kind of nerve root block on the left side, this artery should be kept in mind, especially between the levels from T9 to L2. Now, venous drainage system is of lesser importance, but yes, definitely the anterior and posterior venous system of spinal cord are codominant. And in addition to anterior and posterior veins, small lateral veins also run dorsally. So they drain into inferior vena cava on the left side, on the right side, and on the left side they drain into the left renal vein. So after considering all these things, so this is a detailed anatomy of a neural foramen. If we draw, let's suppose if this is L4, L5 disc, the artery that is arising from here is the aorta, arising from aorta is the lumbar artery. This at the dorsal level, that is why it is marked as a posterior intercostal artery. And if you see, this is the artery of Adamkiewicz. This is the spinal nerve that we are targeting, and this is the radicular artery, and this part is the foramen actually. So kindly keep this diagram in mind. I will be coming back to this diagram, how this is important. So because now comes the concept of safe triangle. So these triangle concept is basically for the neural blocks which we apply in a transforaminal fashion. So this safe triangle is for the supraneural transforaminal epidural injections. As you can see, the roof of the safe triangle is the inferior margin of pedicle. The hypotenuse is the exiting nerve root, and the anterior border is created by the line that is drawn inferiorly from the anterior margin of pedicle. So this is considered to be the safe triangle. This is very well depicted in this diagram also. So next comes the concept of Cambin's triangle. So again, this triangle is infranuclear actually. So the Cambin's triangle, this is a triangular space located over the dorsal aspect of intervertebral disc. Again, this is bounded inferiorly by the superior end plate of inferior vertebral body. The hypotenuse is again formed by the exiting nerve root. And the posterior margin of the triangle is a line which is formed by the end plate inferiorly and superior articulating facet superiorly. So if you see the anteroposterior and the sagittal cuts, or you can see the diagrams actually, so this part is the safe triangle. This is the spinal ganglion, and this is the exiting nerve root, and this part is called as a Cambin's triangle, which is very well employed in the transforaminal endoscopic surgeries also. So why these two triangles I am discussing? So this is the table that summarizes all the things that I just want to convey, because these are the two approaches which are used in the transforaminal lumbar nerve root blocks. So the upper one is the superior or the safe triangle. And if you keep this diagram in the mind, you can very well formulate this table, that is what are the pros and what are the cons of approaching these triangles. So if you approach this superior or the safe triangle, which we call it as, there is a decreased risk of intradiscal injection, obviously, because the disc is in the lower part. Again, there is a decreased risk of intrathecal injection of the dye as well as the drug. Approach can be modified to reduce intravascular spread. Now, coming on to the cons. Increased risk of intravascular injection. Needless to say, there is a radicular artery here, there is an artery of Adamkiewicz here. So that is why intravascular injections have got a more propensity if we try with a superior triangle. And increased risk of nerve root irritation as compared to that of the Cambin's triangle. Now, coming on to the inferior part of this triangle, that is called as a Cambin's triangle or the infranuclear one. So there is a decreased risk of intravascular injection. This is because there are minimal of the radicular arteries in this part of the triangle. So that is why the intravascular catastrophe that happens are lesser as compared to the superior triangle. Again, there is a decreased risk of nerve root irritation as compared to the superior triangle approach. But yes, the one and the most important cons is this inferior triangle is not easy to approach. Whenever there is a hypertrophy of your articular their facetal joints, so it is very, very difficult to approach this triangle. So that is why it may be harder to assess transforaminal epidural space because of the superior articular process, and sometimes the actual area may be smaller as compared to the superior triangle. So take home message is understanding the precise anatomy of lumbar nerve roots is crucial for performing a successful nerve root block. Key structures to consider include the nerve root itself, that is the customer, its relationship with the surrounding tissues as well as the intervertebral foramen. The precise location of the needle is effective for the pain relief, and careful identification and avoidance of critical structures like the dura mater and blood vessels are essential for minimizing complications and achieving therapeutic outcomes. Thank you.
Thank you, Sachin. That was a wonderful presentation. And we'll take questions in the end because some of your questions might be answered in the next slide. And we also have blessings from Dr. Shankaracharya, who is a past president of ASSI and past president of Delhi Spine Society. He's there. Welcome, Dr. Shankar.
Thanks, Guru. Thanks, Dr. Rupinder, and thanks, Dr. Bibu. I'm quite glad that you are starting this session. I hope it lasts long. And we are all learning. Even I learned about the artery importance in that. So we all learn. There's never an end to learning. And thank you. Please carry on.
Sure. Thank you, sir. So I invite next talk by Dr. Vibhudendu Mahapatra. He is a Associate Director and Unit Head, Spine Surgery at Indian Spinal Injury Center. He has a vast experience with nerve root blocks. He is trained in Australia. And welcome, Dr. Vibhudendu Mahapatra. I invite you for your next talk on pathophysiology of nerve root blocks.
Thank you, Guru. And it's a real great privilege being a part of the executive committee of Spine Society of Delhi chapter and taking this initiative and reaching far off to people for spreading the knowledge, and Guru for your great initiative. So I'll share my screen. Okay. Sachin, you have to unshare yourself. Can I now share my screen?
Yeah, done, sir.
Yes, Vibhu, you can share your screen.
Yeah. So my topic is pathophysiology on nerve root block. And we all know that the symptoms due to the disc herniation is usually we always have a notion that it's due to the compression of the nerve root because from the disc herniation. But there are instances where there are a lot of, in the MRI picture, we see a lot of many disc herniation in axial and sections, but there are no symptoms. And even if there is a compression of the nerve root, which is seen in the MRI, but the patient continues to have resolution of the symptoms. And sometimes there is no compression, but you can have pain. So simple compression or mass effect cannot be a mechanism. And so there has to be some other reasons of pain apart from the pressure. So that the concept of the chemical irritation of the nerve root has come by the nucleus pulposus. So if you look at this diagram, so once the nucleus comes out, the nucleus inherently...
Vibhu, your screen is not moving.
Yeah. Sir, I request you to switch to the PowerPoint mode and yeah, sir. Switch it.
So can I do this? Is it okay?
No, Vibhu, it's not full screen.
Visible. It's not actually full screen. So go to PowerPoint mode.
Play. Is it okay?
No, it's not in a slide share. Basically, slide view mode.
Okay.
You are in the keynote, na?
Yes. Keynote में नहीं होता है?
नहीं होता है keynote. I don't use keynote. Play पे ही होगा. या व्यू पे, go to the view.
सर टास्क बार जो ऊपर है उस पे प्ले आ रहा है.
हाँ आ रहा है.
सर वो एक बार
करो.
हाँ वही तो किया था, करके स्टार्ट किया था.
व्यू पे देख ले एक बार.
हाँ व्यू
तो
पे
नहीं तो आपके जो साइड बॉक्सेस है उनको कैंसिल कर दो.
Won't be able to do that. Go to the view. This view.
अभी दिख रहा है?
Go to the view.
हाँ, व्यू पे गया.
I think play should play. Just try the play again.
So this is play.
Uh,
Are you able
जो
to see?
साइड वाला डायलॉग बॉक्स उसको भी बंद कर दो आप, अपने आप हो
सब बंद हो गया अभी. अभी तो प्ले पे है.
Side-
आई एम जस्ट सीइंग माय स्लाइड.
साइड में अभी भी हमें डायलॉग बॉक्स दिख रहा है.
ओके ओके ओके.
तो रजत गाइड करो यार.
स्टॉप शेयर कर लेता हूँ. हाँ,
Go to the first slide, stop share, and then do it.
कौन सा? स्टॉप शेयरिंग आ गया. हाँ, हो गया.
हाँ,
दोबारा करो.
आप अपना स्क्रीन को शेयर करो पहले तो.
वही तो कर रहा था. शेयर स्क्रीन, एंटायर स्क्रीन कर लेता हूँ.
अभी शेयर हुआ नहीं.
एक मिनट.
I think Sachin has to stop sharing.
Sachin has stopped, sir.
आया?
आया.
प्ले कर इसको.
आ गया.
No,
Now can you see my screen?
we can see, but still dialog box can be seen.
I think we can continue.
Is it moving now?
It's not moving.
But we are not seeing the full screen. We are seeing the edit mode. But you can continue, I think. Let's not stick to time.
Go to next slide and we will see whether it is moving or not.
Just switch off the format, no? That sidebar will also go off. So it will look like a full screen.
Sorry, sorry.
Press on the format button on the top right hand side.
Format
बटन. हाँ, दबा दिया. अब आ गया?
आ गया. हाँ.
अब आ.
ठीक है?
Yeah, please.
Correct.
Okay, thank you. Thanks. So I'll just go to the next slide. So you can see the this disc herniation, image of disc herniation. Once the nucleus pulposus comes out, the nucleus pulposus inherently is a very inert material from the birth because it is not exposed to the immune system of the body. So once it comes out, and the nucleus pulposus contains some cytokines like TNF alpha, which is a very strong cytokine, and that is exposed to the immune system of the body. So once its immune system, it sensitizes this TNF alpha, the interleukin 8, interleukin 6, they sensitizes the immune system like lymphocyte, macrophages, which again releases more cytokines. So in this way, so it results in a severe chemical reactions, and because of this chemical reaction, the nerve root is irritated and they result in pain. So if you look at the literature, there's a lot of evidences regarding this chemical irritation leading to the pain. So in this paper, they say that the compression of the healthy nerve roots, which can lead to paresthesia, numbness, rather than sensation of pain. And then they concluded that therefore irritating pain can be contributed to the inflammatory process in the disc herniation. So again, this papers, they say that the disc material also contains a material called glycoprotein, which when comes out through the immune system of the body, that creates a lot of inflammatory reaction, and the pain is relieved because of the by administration of cortisone. So that means with the cortisone, so the glycoprotein causes inflammation, which can be relieved from the cortisone injection. So further, this paper from Vaccaro, they showed that the cytokines levels like TNF alpha, AL1, a lot of the other FGF, intracellular adhesion, molecular 1, they have raised levels in the lumbar disc material, herniated material, which was collected from the surgical view. Again, there is evidence of a higher concentration of TNF alpha in the epidural fat from patients with radiculopathy from herniated disc compared with patients suffering from other types of back pain. So this supported the result of a role of TNF alpha in pathogenesis of radiculopathy from herniated disc. And this paper, where they showed in an in vitro study in rats that exposure of the TNF alpha caused Schwann cells activations with edema and early changes in myelin integrity within 24 hours. On the right side, we can see the images. This is the initial nerve fiber which is exposed to the TNF alpha in early changes, and within 7 days there is Wallerian degeneration of the nerve fiber. So the nerve root injury and pain is caused by TNF alpha, which was concluded in this paper. So there is also evidence of high level of phospholipase A2, an enzyme that helps to regulate the initial inflammatory cascade, and has been demonstrated in herniated disc material collected from the surgical samples. And in animal models also, this has demonstrated that injection of the phospholipase A2 into epidural space can cause local demyelination and ectopic discharges from the nerve root causing radicular pain. Similarly, interleukin 6 has been shown to have a significant inflammatory reaction around the nerve roots, and it also activates the nociceptors and the C-type nerve fibers. Hence, the mechanism of so all these we have evidence that there is chemical reaction which leads to significant irritation of the nerve root and pain in the as a symptom, pain in the symptom, the radicular in the nerve root dermatome. So the mechanism, the analgesic. So how can we control this? Either we use an NSAIDs or NSAIDs, which is given in the initial form of treatment along with some physiotherapy, or we use a very common way of giving a nerve root injection where we use a corticosteroid. There are also different types of corticosteroids, which will be eventually we will discuss what are good or bad. So the role of corticosteroid is to inhibit the inflammatory cytokines and the inflammation inhibition of the neural transmission in the nociceptive C fibers, and it also reduces the capillary permeability, all leading to decreased inflammation and decrease in pain. So this paper is a review article where they have very clearly showed the role of the anti-inflammatory of the glucocorticoids, how they basically block the different pathways. Different pathways of inflammatory reactions, like they can decrease this mark phosphatase A1, and they also block this path by blocking the annexin 1 and COX2. All these blocks, they reduce the release of the prostaglandins and the interleukotrienes, so thereby reducing the inflammation. So this is basically the pathophysiology of lumbar nerve root, why we use a nerve root block of glucocorticoids to decrease the pain. And with this, I would stop my presentation here. I have a video of the technique for the lumbar root block, which I will show after Dr. Lokhande gives his talk. Thank you.
Vibhu, can you stop sharing? I'll start. Good evening, and we have seen these two important talks. One is anatomy and other is pathophysiology. Anatomy, we've seen it. The foramen looks very, very interesting, but it's one dangerous complications. If I was reading it, there are a lot of incidents of complete paraplegia, and most of them are where people have injected in the safe triangle. It is because of the intravascular, and where most of the cases were particulate steroids. So it's not as simple as this. We must know the technique very well before we do these blocks. So what are the type of nerve blocks? Number we'll just go about, as I told you, there are 16 types of blocks which you can put around lumbar spine in different ways. But the two main which we use is the transforaminal epidural steroid injection and the selective nerve root block, which as a surgeon are very, very important for us, both for a diagnostic purpose and as a therapeutic purpose. The two important things which we require is the needle, the steroid, xylocaine, and a good C-arm and a good C-arm technician. Because unless until you see, it is the 2D, direction, depth, and direction. This is only three things, 3Ds, which can take you to a right place. So this is very, very important. You must learn, spend time on this, visualize your anatomy, as Sachin has said, know your pathophysiology, then go what block you want to give. So surgical anatomy, we've already seen. The most sensitive part, as God also knows it, is the dorsal root ganglion. That is why it has been placed in a foramen. All the spine is protected by the bones around. It is so sensitive that God made another foramen, another strong space for it to protect it from the, but because of the anatomy, the disc or stenosis, this is the most commonly affected and this is the cause of the pain. And all the blocks, you have to be very careful. You have to look at this mid-pedicular line. You always be lateral to the mid. Don't cross the mid-pedicular line. These are two tips which I want to tell you. So this is how the surgical anatomy is. This is one position which will take you to is the Scottish dog. So you learn to make it with your image and then you will know where block to put it. So you can see a facets from here. You can see how the nerve goes below the pedicle. The medial branch here goes, the pars interarticularis. We'll not be talking about even the discogram. If you look into this, you can do all the blocks to one single position. So Sachin's already spoken about it. It is, you must read this thing, especially the arterial supply and looking at how the dorsal and the ventral root ganglion are formed. Then you will understand the significance of this block, whether it is a selective nerve root block you're giving or you're giving a transforaminal epidural steroid. The arterial distribution already spoken about, and this is another thing which we see. So if you, as a pathophysiology, as a spine surgeon, it is important that you do your own blocks. In the pain management, I would not note it. So if the cause of the pain is from the disc, probably the traversing route is affected. So you will give us the cambion block or something like that. But if it is a far lateral disc, you know the root at L4-5 probably will be the L4 root. So probably then you will give a supravehicle or a root block and that. So even if you do a selective nerve root block at L4-5 and you think L5 is the culprit, probably you will give a block below that level. So you will not give it L4-5, you will give it at L5-S1. So one must understand that transforaminal epidural injection is not equivalent to selective nerve root block or nerve root sleeve injection. So what is the difference? So anatomically, it's the you target in the selective nerve root, you target the distal to the division of the dorsal rami. Whereas in transforaminal, it's proximal to the division of dorsal rami. The tip of the needle is always outside the intervertebral foramen in selective nerve root block, where in the transforaminal, you are within the intervertebral foramen. And the type of the block, selective is always diagnostic. So you really need to know your pain generators. So, and you inject only the local anesthetic. You don't inject steroid with it. Whereas the transforaminal is, your target is to decrease the inflammation around the nerve or wash out the inflammatory markers. So you're looking at a therapeutic. You know the cause. You want to do, it will help you both as a diagnostic and therapeutic. So you will inject both local anesthetist and steroid. So volume also is just 0.5 ml in a selective nerve root block, whereas in the transforaminal also never go beyond 2 ml. You cannot inject more. I've seen people injecting 5 ml, 6 ml. Don't do that. And inject a dye, then definitely you'll know if the drug spread is laterally along the nerve root or it is along the nerve root plus medially. I'll show you some of the photographs to see how it is different. So here it is very, very important. The pedicle, mark the pedicle into 1, 2, 3, divide into half. And the selective nerve root block, you are always staying outside the lateral wall of the pedicle. Whereas the transforaminal, you are in the foramen, but well up to the mid pedicular line. So if this is the dye spread, so if you look at the picture on the left, the dye is spreading along the nerve root. So this is you are outside the foramen. So this is a selective nerve root block. Whereas if you look at on the picture on the right, that is the transforaminal epidural steroid injection. You see the dye is in medially also and is spreading along the nerve sheath. So this safe, Sachin has already spoken about this safe triangle. It is quite safe. Apart from that, high vascular elements are there. Otherwise, it's relatively a safe injection. So you have to go into this, get a good route for transforaminal block. And beyond the dorsal rami, distal to that is the selective nerve root block. We've already discussed about the anatomy of this. We already seen why a safe triangle, minimum nerve injury in less intrathecal or vascular injection approach is referred to as safe triangle, is termed as it is subpedicular or supraneural. You are above the nerve, supraneural. You are below the pedicle, subpedicular. So this is how you target it. You go bit target line is between 1/3, half and 1/3 between the A and B. That's the marking of the superior and inferior pedicle. And you can give your blocks even in a AP view. That is how you people do this endoscopy, transforaminal endoscopy. So that is also another technique of putting the needle. So if you can do your blocks, you can eventually become a very good transforaminal endoscopic surgeon. And your target in this is around 6 o'clock where your needle should be. People generally bend the needle and the bevel end, and then that manipulation becomes very, very easy for them. So this is now the safe triangle. This is one of the ways where you have to now go subpedicular and go into the anterior to the root and posterior at the dorsal of the periosteum of the vertebral body. So this is another way of targeting the supra-safe triangle. And then this is an ideal dye spread. So you can see the dye from medial going along the root into the root sleeve. This is where on the left you can see if you have gone intrathecal, or on the right where you can see you had a vascular injection. These are two dreaded complications which can result in neurological deficit, cardiopulmonary shock, and even death has been reported. Paraplegia has been reported. Cambial triangle, Sachin has already spoken to it. This is quite a safe area to go in, and this is how you target. So you are camping at suprapedicular or subpedicular approach, depending on what route you want to target. So that is important. So again, in the Scottish doggy, where you have to just go to the superior and the inferior process and target around the disc level. Similarly, in the AP view, this is how I have said your needle should be around the disc area. So in the lateral view, you are well below the nerve root. This is an ideal dye spread as seen in the S1 root. It is important that you have to go into the S1 foramen. So the needle should be little more of the foramen because the nerve runs in the inferior lateral. So once we'll come to Pramod and Mahapatra will explain how they do it. But in general, the principal epidural injection should be used in combination with other active conservative treatment and modalities, and not as a standalone treatment for long-term relief. Injecting multiple regions or performing multiple procedures during the same visit is not recommended. You will not come to know, especially selective nerve root block. You have to do it one by one. And no more than 2 levels of transferon block should be done in one go. Thank you.
Thank you, Rupinder. And that's our President, Delhi Spine Society. Again, we'll go to the next talk now by Dr. Arun Banot. He's a senior spine consultant and executive committee spine, Delhi Spine Society. He will be talking on basically imaging in nerve root blocks. Dr. Arun?
Yeah, Guru.
Yeah. So you can share your screen. And
Is my screen visible?
No, not yet.
Not yet. Allow. Now?
No.
No, not yet.
Have you unshared yours?
Yes, yes. Share press करना.
Share कर दिया.
No, हुआ नहीं.
I am not logged in from the Zoom
you are-
app. I am logged in from browser. Does it have some impact on it?
No, you are not logged in from the presenter.
he has logged in from the presenter. He has logged in from the. So browser doesn't matter. Zoom works in
Yeah.
all the
So
browsers.
why is it not ticking?
Are you not able to see share screen option?
I am able to see share screen, and it is prompting me also choose content to share.
So you don't you go there and share your whole screen.
Yeah,
Yeah.
I'm doing the whole screen share.
Yeah.
You open your presentation, na? And then share a screen.
First keep your presentation open on the
It's
screen
already
and
open.
then share.
It's already open.
पर बनोट sharing नहीं हो रहा.
Maybe we go to the next presentation. I'll come back. We don't waste time.
We can try for a minute. We have a
Because this is a
2 minutes.
sequential Banot. Because
Yeah. So tell me how to go about it. Allow to share.
So share screen. You are chosen your share screen option.
Yeah,
I've
it's
sent- yeah,
coming
now
now.
we can see.
Yeah.
Yeah, we
Now
can-
it is. Okay. Okay.
Now go to
Yes.
your presentation.
Yes.
So thank you for having me here.
Make it full screen. Yeah.
I have made it full.
ठीक है.
No. Can't you see the full screen?
It's fine now. It's fine now.
Yeah.
It's fine. It's fine. It's fine, Banot.
Okay. So as our previous speakers have very nicely explained the anatomy, and Dr. Rupinder mentioned about specifically transforaminal nerve root blocks. So my brief today is to talk about how to visualize the anatomy, specifically in reference because most of these injections we do under image intensifier X-ray control. And many a times visualizing that anatomy is important, and understanding how to go about the blocks. So I'll be trying to focus on certain difficult areas which are not usually seen, like epidural blocks are given mostly by anesthetists. And if orthopedic or other spine surgeons do, then usually they tend to stick to caudal epidural. But personally, I prefer lumbar epidurals are much superior. And if you can visualize them better on X-ray, then you can do very good epidural blocks by yourself. And I usually don't use the blunt needle. I use the spinal needle as well. So I'll just mention how we go about it. And then sacral nerve root block is one area which not many people are able to do very easily. So, and then SI joint block. So these are the things that I'll cover, how to visualize the X-ray for doing these blocks. So this is our main standard picture, which is a AP Siam picture. And if you look at it carefully, you have to visualize that which window you are going to approach and how to address that particular area. Now, see this. And this is the APN lateral standard image that we use. Now, if it is for L5S1, this is the L5 lamina and this is the S1 lamina, and we can very well see that the and this is the L4 lamina. Now, carefully visualize the relationship of the end plate to the laminar window. So at L5S1, we all know that the lamina is just at or at the just above the edge of the L5 end plate. So it is very easy to visualize this window, and many times we use this window at L5S1 to do an interlaminar epidural block. And epidural blocks usually tend to spread 1 or 2 level above and below. So it doesn't matter, even if you do not have a window at L4-5, you can do a L5S1 epidural block if your pathology is at 2 levels, and you can see the dye spread upwards as well. Now, if you see the L4-5 window and compare it with the L5S1, you see the L4 end plate is quite above the lower edge of the L4 lamina. So here, the giving an interlaminar epidural block will be a challenge, but if you can visualize this picture, you can still very well do it even at the above levels. Now, how do we imagine the blocks? Rupinder has already shown you one way of doing transforaminal blocks. I'll just try to show how he already mentioned that for transforaminal endoscopic surgery, you can use a AP and a lateral view rather than the Scottish dog oblique view. And I usually tend to prefer that because this allows you to have a good practice of doing these procedures. And if you want to graduate subsequently to a transforaminal endoscopic surgery, if you want to. Now, when we see this picture, we always tend to collate the neural anatomy and the soft tissue anatomy onto the intraoperative X-ray. So this is the thecal sac, which is lying between the two pedicles, and this is the exiting nerve root at one level, and this is the traversing nerve root, which tends to become the exiting nerve root at the lower level. Now, if we have to give a transforaminal epidural steroid, usually what we do is we focus our needle at this juncture. So you can see Rupinder already said medial pedicular line should not be crossed. So that is correct, because if you cross, then there is a chance of a dural perforation. If you keep your needle tip shy from the medial pedicular line, so this is the medial pedicular, I'm sorry, I'm not able to use the cursor. Anyway, and in the lateral view, it has to be just shy of the posterior vertebral line. That means 1 to 2 mm posterior to the posterior vertebral line. So this is your transforaminal epidural steroid. But if you want to give a transforaminal selective nerve root block, in that case, we would be aiming our needle to this part, which is the under the pedicle, right? Now, when we have to give a interlaminar epidural, we usually aim at this window, which I have marked at L5S1, just below the L5 lamina. The other safe way is you can aim your needle initially at the upper edge of the S1 lamina. You hit the bone, and once you hit the bone, then you can withdraw the needle and slightly angulate it cranially, and then you can penetrate the ligamentum flavum. And then again, you can use that same maneuver of injecting air, and then once there is vacuum, you can also use dye to inject into the area and confirm the epidurogram with the dye. So this is how we go about the transforaminal and interlaminar epidural steroids. Similarly, this picture shows how you can do a similar interlaminar epidural at even upper level L3-4. The only challenge is that you have to visualize the lower edge of the lamina clearly by orienting the C-arm in either craniocaudal or caudocranial, depending upon how the lordosis of the patient is. If the patient has too much of lordosis, then you will have to tilt your AP view C-arm in a significant degree, and then only you will get this picture. Now, the importance of having a correct visualization of the C-arm. Now, if you see the picture on the top left, that is showing lateral view of the L4-5 intervertebral foramen. But if you carefully see, there is a overlap of the iliac crest, because the C-arm tube is not perpendicular exactly 90 degree to the area of interest. But if you see the picture on the middle, the lower one, you see it is exactly in line. You can see the two end plates, sharp end plates, and the whole vertebral foramen. So this is a true lateral view that we need to see. Otherwise, if you do not see and you just rely on the upper picture on the left, then you are going to have a off center, and sometimes you will not be able to negotiate the anatomical hindrances like the superior articular process or the iliac crest. It is pertinent that you have to have a good direction of the C-arm to see the exact perpendicular. Now, when we do S1 nerve root block, if you see the picture on the middle, you just see the pedicle of S1 and you cannot see the intervertebral foramen properly. But if you tilt the because the S1 is the sacrum is lifted upwards, so that is why, and the sacral foramina are not in same line. So the posterior sacral foramen and the anterior sacral foramen are offset from each other, and that is the reason S1 is not easy to visualize. But then if you tilt your C-arm caudocranial, then you can visualize this picture where you can see these intervertebral foramens just under the pedicle of the S1 vertebra. So this is the window where you will introduce your S1 nerve root block through the intervertebral foramen at S1. Now, when we have to visualize SI joint, this is the tentative orientation of the SI joint. First is that you have to tilt it caudocranial at about 30 degrees angle, 25 to 30. Sometimes it can be even more depending upon patient to patient. And the second is, if you have to see the ipsilateral, then you have to tilt the C-arm on the same side, or for the opposite SI joint, you have to tilt the C-arm on the opposite side, as shown in the picture below on the lowermost single picture. So with this orientation, you can see the SI joint. Specifically, we aim our needle in the lower part of the SI joint because that is where some potential space exists for introducing the drug. So this is for the ipsilateral on the left side, and the right extreme is for the opposite side SI joint visualization. So this is how we visualize the various anatomical structures utilizing the orientation and angulation of the C-arm. Thank you.
Thank you, Dr. Arun, and you can stop sharing your screen. So now, after image anatomy, pathophysiology, and we know different types of nerve root blocks, and we know how to position our C-arms for that, and what we need to see under our image intensifier. Now we have our guest speaker, Dr. Pramod Lokhande, eminent endoscopic spine surgeon from Pune. He is a senior consultant and head at the Jupiter Hospital, Pune. So he will be taking us through the steps of lumbar nerve root block. I welcome you, Dr. Pramod. Thanks for joining us, and please continue with your presentation.
Thank you, Guru. Thank you, Delhi Spine Society and President Dr. Rupinder Chahal. It's an honor to participate in this wonderful masterclass series. So my talk is going to be basically a repetition of what most of the other speakers have said. So just try to, it's kind of a revision of whatever has been said. So why blocks? All of us know that low back pain is a symptom. It is not a diagnosis. And most of the times the clinical examination, the imaging studies are not conclusive. And we have to identify those significant pain generators, which is a big challenge for us many times. And this is where the spinal injections, they come in play. So they identify and sometimes even treat, these kind of pathologies. So depending on the pain pattern, whether it's a predominantly radicular or axial, we give different types of blocks and depending on the pathology. And there are different spinal injections available for this. The two most prominent ones which we are discussing today are the selective nerve root block injections, SNRBs, and the epidural steroid injections, which are the epidural ESIs. So what is a selective nerve root block injection? This is my friend Rupinder has already told about it. It's a diagnostic block. So there is a difference between TESI and SNRB. Selective nerve root block injection is basically diagnostic. It is given at the ganglion level. For example, if you have a L4-5 disc herniation, so you give it below the L5 pedicle, and only local anesthesia is used, and hardly 0.5 ml in the lumbar region or very 0.3 millimeter, 0.3 ml in the cervical region is given. 1% lignocaine, plain lignocaine without adrenaline, or to 0.25% bupivacaine is commonly used in these cases. Whereas a transforaminal epidural steroid injection is more of a therapeutic injection. It is a kind of conservative management of pathologies. It should be ideally given in the pathology site. So if you have a disc herniation at L4-5, I think it should be given where the disc has actually come out and touched the nerve root. So we give a combination of local anesthetic and a steroid in such cases. And the steroid is commonly triamcinolone, decometrol, or betamethasone. And reasonable quantity around 1.5 to 2 ml is given in the lumbar region and around 1 ml in the cervical region. So what are selective nerve root blocks? These are ganglionic blocks, and this is where your target is. It is just below the pedicle, above the ganglion, and the target is in between the lateral pedicle line and the mid pedicle line. Ideally, you should not cross the mid pedicle line because then it comes in closer contact with the nerve root. Once the needle is properly placed under C-arm guidance, you inject a contrast. A 0.5 ml of radio-opaque dye is injected. First, to confirm whether it's not in the blood vessel. Second, to outline the exiting nerve root. And lastly, it is for pain provocation. And then we inject a local anesthetic, either 0.5 ml for pain relief, which can be 1% lignocaine or 0.5% bupivacaine, as discussed earlier. So these are the three main components of any diagnostic block. First is pain provocation. So once you insert the needle, if the needle is touching the nerve root, a concordant pain reproduction has to recur in the area of the selected nerve root distribution. Then you inject either with a contrast, which can also cause pain provocation. Contrast usually it confirms the extravascular placement of the needle. The dye should not, or the steroid should not go inside the blood vessel. That is why we inject the contrast and to outline the nerve sheath. And lastly, we give local anesthetic for pain relief. So positive result is considered if there is at least 50 to 70% of the pain is disappeared. So what is the reliability and validity of these injections? So specificity, almost 86% it is specific. It is very specific. Accuracy is 73%. But there are false negatives. False negatives can occur if you inject very less quantity or you inject in the wrong area, either intravascularly or in the epineural regions. Or you can have false positive where you inject too much of local anesthetic. So that is overflow of that local anesthetic drug into the other nerve root, causing pain relief. This is the ideal diagnostic nerve root block, a controlled dual differential block. So what we do in this case is we give two injections, which are almost 3 to 4 weeks apart. 0.5 ml of lignocaine is given in the first injection. You look for the pain relief. Then the second week injection is given 3 to 4 weeks after that. A 0.5 ml of 0.25% bupivacaine is given. And a positive block is considered if there is pain relief almost 50 to 80% with both the blocks. And the duration of relief has to be at least 2 hours with lignocaine or 3 hours with bupivacaine. So this dual controlled block technique is very good technique to identify the correct pathological nerve root. So different types of therapeutic epidural steroid injections, as we discussed before, these are for therapeutic, these are for treatment. And we can either give them by transforaminal nerve root or interlaminar nerve root or caudal nerve root, which is now almost obsolete. So interlaminar nerve root, now, you put the needle through the dorsal interlaminar space, through the dorsal epidural space, then you inject the dye. It requires basically a large volume of injected to deliver the steroid at the pathology side. And the spread sometimes is very irregular. If there are adhesions in the midline, it cannot spread on the opposite side or the same side also. And you need at least 6 to 10 ml of volume of the drug to be injected. Whereas on the other hand, transforaminal epidural steroids, these are direct ventral entry. These injections are given ventral to the nerve root. Less volume is needed. It's very specific. and usually it has better outcomes as compared to interlaminar technique. So this is a comparison of various types of epidural steroids. As I told you, transformal diagnostic value can be used as a SNRB. So direct deposition over the ventral epidural space. Here we have to perform this procedure under fluoroscopy and useful for only unilateral symptoms. If possible, if you want, you can give bilateral transformal epidural steroids and very less volume, 1 to 2 ml of injection is given. It is more specific. And usually these type of injections, transformal injections, are not tried in the cervical spine because of a very high risk of intravascular injection. The second one, interlaminar, I just told that it can be used for bilateral symptoms, intermediate volume, again, not advised in a previously operated spine. So in failed back syndromes, I don't think this is a good idea to give by interlaminar technique. And the last one, caudal epidurals, these are only therapeutic. You cannot use it for diagnosis given through the sacral hiatus, and usually again bilateral. And I personally feel this is less effective as compared to the interlaminar technique. So, but obviously you can practice it in OPD basis also without any need for CM. So the conventional transformal epidural steroid is given in the preganglion, this ganglionic area near the ganglion, as we discussed before, Dr. Rupinder discussed. The second type is a preganglionic injection, which was actually advocated by Lee. So what it does, they say that the efficacy of preganglionic block is much better than the conventional ganglionic block because it's closer to the pathology side. So this is where the pathology is. So if you give a block here, it's not going to work here. You have to block in this region. So a preganglionic block is actually closer to the pathology near the disc herniation. But what we do, our preferred technique is we actually give it in the Campion's triangle, which is closer to the inflamed nerve root. So there is a disc herniation coming out here, which is touching and causing inflammation of the traversing nerve root. So we give on the surface of that disc herniation, very close to the nerve root. So I think this is one of the most specific and most effective way of giving root block injections. So this is the conventional Scotty Dock technique, which most pain physicians or anesthetists they are using. So what you do, you take an oblique X-ray, you look for the Scotty Dock neck, just below the neck, you direct the needle, a 22 gauge needle go directly vertically, and you should not cross the mid pedicle line in the AP view. And once that position is confirmed, you just inject the dye, and you can give the local anesthetic and the steroid combination after that. This is an example. This is a video showing how the injection is being given. So just the needle is put vertically, and once the needle is at the right location, you take the AP view, then you inject the dye. You can see the outer margin of the nerve root and the dye spread along the nerve root. And once this is done, you can give the choice of steroid which you want. So our technique is basically something which we derive from the transformal approach. So what we do is we mark the center of the disc. You have to firstly see that you get an orthogonal view of the X-ray, see that the spinous process is equidistant from both the pedicles, see that the end plates, they appear as single lines. There is no rotation, there is no obliquity there. You mark the center of the disc space in the AP view, you mark the center of the disc space in the lateral view. And once that is done, in case of L5-S1, you might have to take a reverse Ferguson's view like this. And this is how we mark. We take a longer needle, 5 inches needle as compared to the regular 3.5 inches needle, which we commonly use for spinal injections. So this needle, initially you direct it vertically, hitting towards the ventral aspect of the SAP. So that's the safe technique which you do, because you are entering a blind area. So first thing you have to palpate is to palpate a bone, so that you're closer to the nerve root, and that particular bone is the ventral aspect of the superior articular process. So once you hit this needle like this, then you change it. Now, one more thing you have to understand, that this is the shape of the needle, this is the opening of the needle, and this is the tip of the needle. So when you are inserting the needle in a straight line, the needle will never travel in a straight line. It will always turn towards the side of the tip. So you can use this particular property of the needle to do fine adjustments for proper placement of the needle. So you just rotate the needle, and how do you know that the tip, where the tip lies, there is a small hub on the, if you look at the colored, colored tip, outer tip of the needle, it can be either, it's usually black for a 22 gauge needle. You can see there is a small projection. So the projection is the area where the opening lies. So usually the tip is lying on the opposite side. So you rotate the needle accordingly so that this, proper placement is achieved. And once you hit the undersurface of the facet, you withdraw it, you rotate it into 180 degrees so that the tip now faces downwards. And then you advance it so that it comes closer to the disc herniation and closer to the inflamed traversing nerve root to give a effective block. So this is how we go in. So use of the injection is always given at the base of the Cambien's triangle, So what we look for is, see that the needle tip is at the medial pedicle line in the AP view and the posterior vertebral line in the lateral view. So this is a good position. Again, for L5S1 blocks, we have this problem of very high iliac crest. So here it is impossible for us to get inside the spinal canal, get inside closer to the traversing nerve root. So what we do is we use a double needle technique. Initially, the outer needle is 18 gauge needle, which is a regular 3.5 needle, and the inner needle is a 22 gauge needle, which is a 5 inches needle. So what you do, you just curve the tip like this, and first you insert the outer needle closer to the lateral border of the facet. So once that is done, you insert this thinner needle through this outer needle, and then it comes closer to the traversing nerve root. So this is again a very effective way to give blocks. So again, just a last slide, a few words about what kind of steroids you use. Particulate steroids like methylprednisolone or depomedrol, these are very effective. These are long lasting. Their effect is very long lasting. But one of the problems is that they have a very high chances of, causing reactions, causing allergic reactions. And these particular steroids, if they are injected into the blood vessels, definitely they can cause embolism kind of phenomenon. So as far as possible, I've stopped using depomedrol now in lumbar blocks. Usually my preferred steroid is a triamcinolone, which is commonly known as Kenacort or Vicort. So that is my preferred drug in the lumbar spine. Whereas on the other hand, in case of cervical spine, I usually prefer a non-particulate steroid. Usually it is dexamethasone or dexa sodium phosphate. So these are less chances of fatal complications. So in general, to summarize, I think root block injections, you have to decide what is the purpose of giving this root block, whether it is to diagnose or whether it is to treat. And depending on that, we have to select how much quantity, where to give the injection. And as previous speakers have already told us that these are not very simple procedures. These are once in a while, you can get some very bad complications, and you have to be very aware of the vascularity of that particular area. Thank you very much.
Thank you, Dr. Pramod. I request you to stay back for the question and answers. And can you just unshare your screen? And we have a small short video by Dr. Bibhudendu Mahapatra. After that, I invite Dr.
Vibhu, you can share your screen.
Yeah. Are you able to see the screen?
Please. Yes, we can see.
Okay. So just a small video. I think Dr. Pramod has demonstrated very brilliantly the techniques, are different techniques, and the imaging techniques by Dr. Bhanot. So this the patient. We have already discussed the Cambian triangle approach and the subpedicular approach. And I'll just go to one case. Recently, we did a very obese patient which had a L4-5 left-sided disc herniation with significant foraminal stenosis on the L5S1. So having severe L5 pain, I usually prefer the Cambian triangle approach. So I usually dock the needle on the lateral aspect of the superior articular facet, and this is the AP view. This is the needle. It's not very clearly seen, so it's docking at the lateral aspect of the superior articular process of the L5. And here in the lateral, it is just posterior to the facet joint. And here exactly what Dr. Pramod said, that you just reverse the bevel, pointing it downward so that it glides along the facet joint, facet articular process and enters into. So here we can see the needle placement in the middle of the pedicle at around 6 o'clock position of the pedicle, and this needle is at just posterior to the disc space. So then we push the die. So you can see the die. So it's going in. So we can see the L4 nerve root coming and the L5 nerve root also getting there. And so this is how the this is the drug I'm putting in, and the washing out of the L4 nerve root and the L5 nerve root is seen. So this is how it is seen while we are doing the transcambian approach. Now, if we have to see the subpedicular, yeah. So after the L4-5, I gave a L5 nerve root block just below the pedicle. So the needle placement is at just below the pedicle here on the L5, and this is how the the patient complains of pain, severe pain along the same route. So there are two ways of confirming your needle placement is correct. One is the dye, which is seen along the nerve sheath, and the other, the patient complain. We can recreate the same pain along that same nerve route. So this is how the subpedicular approach was done. And this is the small video which I wanted to share with you all. Thank you.
Thank you, Dr. Vibhu. And now I invite Dr. Sunil Katoch, Senior Consultant Spine Surgeon at Max Super Specialty Hospital. Over to you, Dr. Katoch.
Sir, full screen down.
Myself. I need to unmute myself. So now I'll again share.
Yes.
So can you see my screen, please?
Yes, sir.
Yes, sir. Yeah, you can make it full screen down, sir. Yes, sir.
So slideshow.
Yep.
Yeah.
Yeah, so thank you so much, the leaders. I am the second last, and trying to understand and trying to share my thoughts and my experiences of complications and management of these blocks, which are so tough as far as I am concerned. I feel these are no simple techniques. They have very good track record. but I think we must go with caution. As we see during the talks, we have seen the anatomy and the pathophysiology. So many structures around the spinal cord and the cauda equina. There is fat, there is veins, there are arteries, there are nerves, there are dorsal root ganglion, there are meninges. There are God knows how many things which are around these nerves where we are trying to do, a chemical treatment. And all of these are in front of a needle whose tip we are unable to visualize really. We can have two-dimensional understanding of the needle tip, but still we really don't know where the tip exactly is. And I find myself in the pilot seat of this aircraft with so many birds flying around, and I don't know how to land safely. But having said this, it is still good reporting that in the literature, there have been, in the retrospective studies, there are only 0.5% complications. But in the prospective studies, there are about 10 to 15% complications, and some of them are serious complications. And I have personally experienced some of them. So my idea will be, to go slow. Now, what are the complications? I think of these complications related to two main things. One is complications related to needle placement, in which there is injury to nerve sheath, causing a CSF leak or a fistula, making a low CSF pressure signs patient, and or meningitis, and or even a severer thing. Second is injury to the nerve or a dorsal root ganglion, because many a times most of the ganglions are within the root canal, except the L5 root ganglion, which is within the canal. And anything which is irritating to the DRG or the nerve can lead to neuralgia, dysesthesia. Patient complains of vague symptoms which the doctors don't understand, because for them motor deficit is the only thing, sensory is nothing. But patient is what he perceives, the sensation. That's exactly what he has come to us for. Then the next thing is the disc. Inadvertently puncture into disc can many times lead to a aseptic or a septic discitis, depending upon your operative room setup. And these are so very severe symptoms. Patient is unable to really breathe comfortably, or maybe he is frozen in the bed. He doesn't want you to touch the bed, because little bit of movement or coughing or sneezing can cause severe pain, and patient is motionless. Then the fourth structure is the vein or the artery. I just showed you, how many veins are in and around the nerve root. And a bleeding, if it is a little bit, it can be fine, but anything more than 10 ml may cause a hematoma. And if the hematoma is big enough, it can cause, again, the issues which we really started with, the pressure on the nerve. Or an inadvertent puncture into the artery, causing a hematoma of the same variety. And if we have injected into the artery, it can lead to embolization, sometimes leading to a thrombosis, which can extend proximally and distally and leading to a neurological deficit. Also, in my injury to the nerve, if we are injecting next to the nerve, many a time sensory symptoms are pardonable. But if we are injecting long-acting local anesthetics, it can be causing motor deficit for a longer time, causing a worry both to the patient as well as the doctor. So my thought is that we must be very sharp to respond to the patient for understanding the placement of the tip of the needle. Next thing is the complications related to medicines which are getting injected through the needle tip. The first basic thing is contrast, because that is what will make us understand as to where the needle is. And if the contrast can cause allergic or anaphylactic reactions, they can be really devastating. And we must be prepared for all this. Wherever we must do these procedures, it should be equipped with a life support system so that patient can be immediately resuscitated. For the local anesthetics, there are short and long-acting local anesthetics, which can cause allergic, anaphylactic, or motor complications, as I just mentioned. And some of them can be really serious. This chart shows a list of these local anesthetics showing the duration and the onset of action. Simplest thing is lignocaine to start with, and then you can mix it with something longer acting, which can stay for a longer time if your placement of needle is fine. Now, the main drug, which is just mentioned by Dr. Lokhande, steroids, particulate steroids and the non-particulate steroids. Unfortunately, we do get dexamethasone, but we don't get it without preservatives. So the dexamethasone that we inject is most of the time with preservatives, or triamcinolone, which probably has longer effect, is used more commonly. So these are some things which we cannot change really. Some more medicines are coming in the way, and let's wait for them. Once the injections are done, these are some of the slides borrowed from my pain consultant, showing that we must be very, very sure, especially like Dr. Mahapatra said, in a 110 kilos patient, the x-rays may not be very clear. So we must spend time, like Dr. Rupinder also said, you need a good technician and a good x-ray machine to give these injections from, because that's the crux of the treatment. This is another X-ray showing contrast, given in the epidural space, but it is landed up in the intradiscal space, most probably because there is a disc which is extruded, and from that route it has gone into the intervertebral space. Third is calcified aorta might sound like contrast extravasation, but we must study our plain X-rays before we start doing that. So positioning and placement of the X-ray machine is of vital importance, and we should not overcome any step. That's why we must make our own SOPs so that we don't shortcut any procedure to avoid these complications. To show some of these pictures picked up from the net, this is an epidural hematoma, which is causing severe compression, which might need evacuation if there's neurological deficit. And please listen to your patient. Patients are never wrong. And this is one slide showing discitis. We have faced a few of these after the injection treatments. And believe you me that it's a very, very tough situation. They have no faith in medical system by the time they have this condition. And whatever you're trying to tell them, they are scared. They have neurological deficit and they have immense pain, severe anxiety, and horrendous attendance to face. So to give a tangible solution will be a tough task in these kind of situations. So to summarize, I will say that each complication is a real-time complications. And howsoever innocuous it may seem to be, listen to your patient carefully to realize what has happened. It may be a very simple thing, but our anxiety and their anxieties, if added together, make situations worse. So please listen to them carefully, examine them with a positive scientific mind, and many a times you will be able to figure out a solution. Please image them at the earliest. Use contrast if possible. Rest is an important part of dealing with most of these issues. And NSAIDs, as mentioned earlier in the lectures, I think it helps a lot. Use anti-neuralgia medicine, all those gabapentins and gabapentins and other neuralgia medicines. Most of them are anti-epileptic pregabalin and oxcarbazines, and neuroleptic medicines, because any pain, you know what is pain? Described by Sherrington in Samson Wright physiology books. Pain is a psychological adjunct of a physical abnormality. And we must treat their minds along with their symptoms. And that's why we must understand and give them a decent amount of neuroleptic drugs. There is no harm being friends with the psychiatrists to understand your limits to giving these neuroleptic medicines, because these help a long way to douse the pain. Then use steroids for chemical or allergic response whenever possible. And if there is a significant compression or infection, I think early surgical intervention will be very fruitful in managing these complications, which to start with are so innocuous. We just told these patients, nothing, we will go to the OT, we'll give you one injection and you will be fine. And they have landed themselves into a serious trouble. I have not mentioned neurological deficit because I dread these complications. And thank you very much for having me on the board.
Thank you, Khattar sir. That was a very wonderful presentation. And we have a last speaker of the day, Dr. Rajat Mahajan, again a senior consultant at Indian Spinal Injury Center. Over to you, Dr. Rajat.
Hello, hi everyone, good evening. So I will be giving the last talk of the session. So I will be mainly focusing on the literature review and what is the evidence. Is my screen visible?
Yes, Rajat.
Yes.
Okay. So I will be talking about the lumbar injections and literature review. So what is the evidence for these injections? So I will be quoting a lot of papers in this section. So it might be a bit boring, but I will give the exact, I will be talking scientific. I will be just quoting the literature and what is the evidence for these. So the questions that I will be covering in this will be the indications. What are the indications and what is the evidence for them? When do we switch over to the surgery? What does the literature say? When we say that, when we can go to the, when we can stop the blocks and go to the surgery, what is the evidence for transforaminal blocks versus surgery, which is better? And which steroid to use, particulate versus non-particulate, what does the literature say about it? Then again, preganglionic versus conventional ganglionic. Like most of the speakers have talked about the Kamens approach as well as the subpedicle approach. So what does the literature say, which is better? How much drug to inject? You can inject 1 ml, 2 ml. What does the literature say about it? What are the prognostic factors? Which patients are going to benefit more and which are the patients which are not going to benefit more with these blocks? So I'll be talking all about them with the literature. So coming on now to the first topic, which is the indications. So as such, in the indications for when can we give these nerve root blocks? So as such, there are no strict guidelines in the literature. Daniel Ryu had recommended 6 weeks of non-operative care with NSAIDs physiotherapy before recommending block. But, this was just subjective. Further, he suggested that at least 4 blocks be tried before suggesting surgery in the lumbar disc prolapse. This was as per Daniel Ryu. So he had published an article in 2000, which was published in JBJS. And this was the article which was published. It was a prospective randomized controlled trial, and it was a double-blind study. And it studied the effect of nerve root injections on the operative treatment for the lumbar radicular pain. So they said that more than half of the patients could avoid surgery with the lumbar disc if they are given the blocks. But they advised using these blocks in the lumbar canal stenosis patients. Again, there is a meta-analysis which has been published recently in the Pain Physician in 2021, which talked about the efficacy of the transforaminal epidural injections in the disc prolapse. So they said that there is a level 1 evidence for the use of the transforaminal nerve root blocks for the radicular pain for disc herniations. That means these blocks are really effective, especially if they are given for disc prolapse. And there is a level 1 evidence for that. So it is not that many times people say that it is a sham procedure and probably, this is the natural history that probably the patient will get better. But these blocks have got a level 1 evidence that they do really heal the patient. Again, this is a very important trial which has been published recently in Lancet Journal. It is a nerve study. It compared the effect of surgery versus transforaminal block. It was a randomized controlled trial, and it was a first multi-centric study which has been published in the Lancet Journal. In this, at least around 11 centers were there, which are all in the United Kingdom. So this study brought about a very important conclusion that for the patients with sciatica secondary to herniated disc, TFESI should be considered as a first invasive treatment option. That means before advising surgery to any patient, the TFES should at least be prescribed to him, because this has been shown that it can obviate the need of the surgery in most of the patients. So my take-home message for the indications will be that transforaminal epidural block should always be tried before recommending surgery, unless contraindications like motor deficit or Diaquinus syndrome exist. Obviously, in those, the surgery is the first priority. It is recommended to use non-invasive methods like drugs, physiotherapy before for 4 to 6 weeks before even giving blocks, but this duration is controversial. So in my center and in my opinion, it might be reasonable to offer a first line of treatment of these blocks also if there is a severe radicular pain. Okay. But this is still a matter of a debate, and there is no recommended period, before which, you can give a block to a patient. So it is still controversial. So coming on to the lumbar canal stenosis. Are the TFEs indicated in the lumbar canal stenosis? What is the evidence? So this was a research article which has been published in a pain journal, and they said that for the grade 1 and grade 2 spinal canal stenosis, these blocks, they gave a good pain relief, but the pain relief in lumbar canal stenosis is slower as compared to the disc prolapse patients. And in the patients with grade 3 canal stenosis, the pain relief was observed after 6 months of injection. That means if the patient with the lumbar canal stenosis is there still and they have a radicular pain, these blocks can give good pain relief, but the patients will have a pain relief slower as compared to the disc prolapse patient. Again, in this patient, in this meta-analysis, which I had also showed earlier for a disc prolapse, this shows that there is a level 4 evidence which supports the use of a transforaminal epidural injection in lumbar canal stenosis. For the disc prolapse, there is a level 1 evidence to use the transforaminal nerve root blocks, but for lumbar canal stenosis, the evidence is level 4. So where to inject and what is the evidence? So as the previous speakers have already talked about the preganglionic versus ganglionic, the conventional TFES that we use is mostly ganglionic, and the drug might not be able to reach to the affected level. For example, if you have a disc prolapse at L4, L5 level, so in the ganglionic approach, we give the block at the below the pedicle of the L5 nerve root. But many times, this drug might not be able to reach to the affected disc, that is L4, L5. So the preganglionic or retrodiscal injection drug is given at the cephalad level near the disc. There are more chances of it washing away the inflammatory mediators. So for example, this is the disc at L4, L5. The conventional approach of TFES is to block this nerve root over here. But the problem is many times if there is a severe stenosis, the drug might not be able to reach the affected level. So the preganglionic approach or the Camlin's approach is you give a drug over here so that the inflammatory mediators can be washed away in a better way. But is there any evidence that the pre-ganglionic approach is better than the conventional approach, or it is just, one's experience? So let's see. So this was an article which was published in Korean Journal of Radiology, in which they had compared the pre-ganglionic versus the conventional approach. And they showed that the pre-ganglionic had a better therapeutic value, better therapeutic effect on the radiculopathy as compared with the ganglionic approach. Again, this is another article which also compared the it was a prospective randomized control trial which compared the effects of pre-ganglionic versus the post-ganglionic, and they also showed that the pre-ganglionic approach had may be considered as an alternative to the ganglionic approach, especially when there is severe stenosis and the needle cannot be advanced more medially. So it can be considered as an alternative approach. And also if there is a severe foraminal stenosis in which the subpedicular approach might not be able to deliver the drug. So again, they showed that the pre-ganglionic is better as compared to the ganglionic. Then there are also many research papers in which they give both the ganglionic as well as the pre-ganglionic in the same patient. But they have shown that these patients get a good pain relief, but but there is no definitive evidence that if there is any benefit of combining both the pre-ganglionic and ganglionic versus pre-ganglionic only. So there is no as such consensus onto it. Again, there was a case control study which compared the ganglionic versus pre-ganglionic, but they concluded that TFES performed using a retrodiscal or the classical approach had similar effects. So this study showed that both the approaches had almost similar effect on the pain relief of the patient, whether you do pre-ganglionic or ganglionic. This was again a review article, meta-analysis, which showed that the pre-ganglionic had a statistically significant chances of effectiveness in the treatment of a lumbosacral radiculopathy. So the take-home message will be the retrodiscal or the pre-ganglionic is better for pain relief than the traditional transforaminal epidural block, as per the literature. Now, which steroid to use for lumbar blocks? As most of the previous authors have already talked about whether to use a particular or a non-particulate steroid. The particulate steroid, they offer a slightly better pain control over the non-particulate steroid because they tend to stay there for a longer period of time. But the problem is in the particulate steroid, if they are inadvertently injected into the arteries, then sometimes spinal cord ischemia has been seen, especially if you inject the particulate steroid in the artery of Adam-Kiewick, which can be sometimes as low as up to L4 level also in some patients. So there has been a multiple meta-analysis which has been published, and so this was a meta-analysis which was published, and they showed that there was no significant difference between the particulate and the non-particulate steroid in the pain also. So both the steroids, they give equal pain relief when injected, and therefore they suggested that it is better to use non-particulate steroid considering their less complication rates as compared to the particulate steroid. Again, this was a review article which was published in European Spine Journal, which showed that the particulate steroids, they were not better in giving pain relief as compared to the non-particulate steroids, and they also suggested to use the non-particulate steroids. So the take-home message will be non-particulate steroids might have less pain relieving capability as compared to the particulate steroid, but they are safer and they are recommended to use. Now, how much drug to inject? Whether you should inject 2 ml, 3 ml, 4 ml. So there is no such concrete evidence. So I will just quote the literature, what the various papers are saying, and then we will talk about it. So this was again a pain article. So most of the literature on the nerve root blocks is from the pain physicians. Very few articles are from the surgeons actually. So they compared a 8 ml block versus the 3 ml block, and they said that both of the that 8 ml block was more effective in controlling the pain as compared to the 3 ml block. So the volume had an effect on controlling the pain. So they said the more you inject, the better it is. So 8 ml had much better pain control as compared to 3 ml. Then this was another article in which
can we wind up first?
Sir, sure. So this was another article which showed that at least 10 milligram of steroid had to be given. Now coming on to the prognostic factors. So which are good factors and which are bad factors? Which patient will get good pain relief and which patients will not get good pain relief? So this was an article which was published in NAS, and they showed that low-grade nerve root compression has a good prognosis. Central foraminal and extraforaminal disc are all good. All will have good pain relief. Subarticular disc has a bad prognosis. These patients might not have good pain relief. Radicular pain due to LCS disc, all will get good pain relief. Milder radiculopathy patients will get good pain relief. And there was no association with age, sex, BMI, smoking status, employment, workman's compensation. They did not find. They have no influence onto the pain relief. Thank you.
Thank you, Rajat. That was a wonderful literature review. I think we all learned a lot. Dr. Sachin, can we
Yes,
have
sir.
a few questions? Yeah.
Yeah, so we have a couple of questions. I would say there are 8 to 10 questions. I think the listeners are quite interested in the whole masterclass that we have presented. So Dr. Ranjay Kumar has a question that how to avoid tingling and numbness after nerve root block.
Rajat,
So,
can you
Dr.
stop your screen sharing so all of us are on the screen?
Dr. Shankaracharya is here, and sir, can you take up that question, please? Dr. Shankar.
Yeah. Hello, Sorry, I didn't hear the question. What is the question?
So, sir, how to avoid tingling and numbness after giving a nerve root block after the post-procedural tingling and numbness? Is there a way to avoid it?
And obviously, if you've done the nerve root block properly, you would not get tingling. Basically, you have touched the nerve root, you get a sharp pain or you get a tingling. And sometimes, if you inject a little too much, you may get numbness. Usually, this settles after some time. But I think the most important thing is to be careful when you inject and make sure that you are not very close to the nerve. You have to besides the nerve, na? That's the
Dr. Pramod, is there any particular pathology where you expect more of a tingling after?
I think we get this kind of tingling numbness in a disc herniation associated with very severe stenosis, because the space is very small there, and maybe there are a couple of osteopods protruding also. So that is one reason for that. Secondly, as Shankar sir rightly told, if your technique is improper, if you're actually hitting the nerve root, when if you're very uh, crude with your handling of the needle, in that case again, we can have this kind of a problem.
I think, Sachin, we go from, I think, let us start from the number 1. So we will not. So the first is, do you provide any certificate for this attending this webinar? This is an important question from one of those. As of now, we don't know. It will be very difficult for us to verify the attendance. So it's not a good idea for us to give a certificate. And what is the signs that a root block has been done correctly, and what are the perfect sets of patients for root block?
That is already addressed, Rupinder.
Yeah.
Okay.
How many times a root block can be given or repeated? I think Rajat has highlighted it. This literature, they say you can give it up to 4 times, Rajat?
Yes, sir. As per the literature, up to 4 times in a year, the nerve root block can be given. Most of these guidelines are by the pain physicians.
I would differ here. I think at intervals of 6 weeks to 3 months, you can give multiple times root blocks, and I've done this over years. And sometimes I've given more than 8 or 10 root blocks to patients who are reluctant for surgery, who have not fit for surgery, who are fairly male and old. So I have given even there. I know of some doctors have injected multiple times over years. So I don't think there is any hard and fast rule saying how many times you can't give. But of course, each time you give, you're depositing steroid particulates there. So those are sometimes when you operate on them, you find a lot of adhesions, and you also find particles matter there. That also has to be taken into cognizance. But you have to warn the patient that giving too much injections is not good.
I think the good idea is if you keep injecting it every month, and then probably you don't operate it yourself because you'll have a lot of fibrosis, and then I think
The reason behind it is because why they say 4 injections. There are two school of thoughts. One, Dr. Shankaracharya has said that the more number of we do, because there is a concept of getting the local absorption of the steroid also. So the maximum amount of steroid which can be given safely without causing any systemic effect is 3 to 4 times in a year. So that's the reason behind it. But you can give it as many as a times. But having said that, it might cause more and more on fibrosis and inflammation around the affected area.
Bernard, does it affect your surgery?
Oh, definitely.
Usually, no.
Okay.
Because we have seen people with, when we go in for a discectomy after a couple of injections, the vascularity is very high and the bleeding chance of bleeding is little more than people who haven't got these kind of injections.
Probably endoscopic surgeons use a lot of saline, so that does a blunt dissection.
Yeah. That they don't find.
No, it
But that is
probably is
true
also
even without
depends upon
injecting them.
visualization. So the scope is actually giving you much magnified view.
So any comments on post-operative infection after giving these steroid injections we perform with surgery? Then are there any increased chances of surgical site infections? Have you encountered that, sir, in your practice?
Not in my experience.
Very difficult to pin it out on steroid because there can be a lot of other causes of infection. So just to say a little problem. So what precautions to be taken before posting a case for blocks? I think this is a very generalized question. Is skin infection a contraindication? This is a genuine thing.
Yes, it is. Yes, it is.
Yes.
I think Rupinder, this was very comprehensive, but I think you should have once somebody should have mentioned. I think Atosh should have mentioned that a lot of pain physicians are using ozone. I think that is reduced, and I have seen a lot of discitis with ozone with steroids. So you can get a subclinical discitis in patients. Then you go and operate, and they may have long-term problems with pain. So definitely in your history taking, you should ask if you have multiple episodes of steroid injection, and if they are diabetic or they have poor immunity, then you should be very careful, or to explain to them that since you've had these injections, you are diabetic and your HbA1c is not very good, you may have an infection post-op, and that is probably because of your morbidity rather than surgical. So that also.
One more thing, Rupinder.
Yeah.
So there was a mention about particulate steroids. So one must know that Depomedrol has a clear product monograph that says it is not meant for epidural use. So if somebody is keen to use particulate steroid just for the medical legal purpose, it is preferable to use Kinacort, as Dr. Pramod said. So despite the benefit, it is more of a medical legal issue also. So try not to use Depomedrol.
Yeah, Arun, the ideal size for the steroid is the betamethasone, which is not available. Which is not available in India. So
I think that there's a pain physician.
Next second drug of choice is Kinacort. Kinacort, which
but I specifically forbade Depomedrol because if there is any issue, the product monograph will say that this is not specifically labeled not to be used in epidural.
Point very well taken. Point very well taken. Absolutely right.
Sir, we have next question on this only. What is the dose of steroid that we use? Dr. R. Hari Krishna has this question.
That I think has been answered in the lecture. I think that has been answered.
And even in the literature review also.
Yeah, it has been answered. So I think let me summarize it. It is very, very important. 2-3 more points which you come to is when you are putting the patient prone, first look at your whether your table is radiolucent, whether your area of putting an injection and movement of C-arm is freely in a radiolucent area. Make sure it is done in an OT sterile environment. Don't treat it as an OPD procedure. Please clean and drape the patient properly and put all your monitor his blood pressure, heart rate, everything, and do it in OT complex with all sterility with an anesthetist standing by and a good technician. And Then after the injection, and please keep communicating with the patient when you are doing it. Don't just poke him, right? He's not from Mahabharata that he'll tolerate it. So even if you are cleaning the patient with betadine, if you can understand, if you have gone through that procedure, it's a cold. So if you tell the patient that you may feel little cold, otherwise he will just keep moving around. So every step, please talk to the patient, and it is very, very important what you are doing it. And before injecting, please aspirate it. This is very, very important.
Rupinder.
Yeah. And then probably then just monitor vitals. And once the injection is finished, patient is supine again, monitor the blood pressure again. So at times, because of the intrathecal or something, the BP may fall. So keep monitoring the patient at least 1 hour post injection. So thank you very much. Vibhu, please, for the vote of thanks.
Yeah.
I thank all the speakers to have taken their important time out and to make this first masterclass series of our Delhi Spine Society chapter is very successful venture. And I thank Guru also to take this initiative and to get it here. And we will be, this is the first among the many to come in, and we will be again be back on the second Wednesday of the next month with another interesting and very basic topic. Thank you. Thank you all.
Last, I would like to thank the Sun Pharma and Pawan, Rajesh Agarwalji, Mr. Abhijit, and Dr. Sudhakar, who actually worked tirelessly for this webinar. And they all brought us together here. I thank Sun Pharma wholeheartedly. Thank you.
Thank you so much, sir.
Thank you, Sun Pharma, also from us. Thank you.
Thank you, sir. Thank you so much.
Thank you, everyone.